Hello and welcome everyone to this session on rapid revision of surgery part 8. My name is Dr. Jhanvi. I am the anesthesia educator on Unacademy, and today we are going to be continuing with our series of rapid revision of surgery. I hope you guys are all able to see me and hear me well. There was some problem with the link going out for the class. Yes, I can see that the streaming is absolutely fine. So today we are going to be discussing part 8, which is urology. For all of you who are new to this series, we have been discussing surgery for the past 1 week, and we have finished esophagus, stomach, small intestine, appendix, intestinal obstruction, breast, oral cavity, salivary glands, thyroid, and neck swellings and other swellings in surgery. So we've done quite a few of it, and today we will be starting off with uro. I will be taking today and tomorrow to do uro, because I think around kidney will get done today, and tomorrow urinary bladder and ureter. So let's begin without further ado. This is the Telegram channel where we post the links to all our classes. Let's Crack NEET PG. So make sure you're a part of the Telegram channel. Now, for those of you who want to learn anesthesia, I'm also taking a plus course every day from 19th to 24th, 4 to 6 p.m. in the evening. And this plus course will help you clear out your concepts as well as study whatever is important for the exam from point of view of anesthesia as a subject. The Plus subscription on Unacademy can help you get access to both live and recorded classes. You can learn from India's top educators, you can compete in live tests and quizzes, and you can study on the device of your choice. The iconic subscription is a partnership between Unacademy and PrepLadder, which will help you get the best of both in the form of live lectures of Unacademy and video lectures of PrepLadder. In our special classes, we have raise a hand option. You will get a notification before the class starts, and you can also download the PDF at the end of the class. We have a highly effective question bank which has 25,000 plus high yield questions. These are our FMG toppers, and we are coming up with the NEET PG combat tests on this Sunday, and I'm happy to announce you guys that the combat anesthesia questions have been set. So we have short subjects and medicine this time, and okay, it's not very easy, but it's a little difficult because the prizes that are there are very big. So we have prizes worth 10 lakh rupees that are there for this combat. So I really try, I'm telling you guys to go ahead and try for combat, so that you can try for all those Amazon vouchers which are available. We have raise a hand option in our classes, in which you can speak to the educator directly live, and we also have these batches which are going on right now. So the Target NEET PG 2022 MCQ discussion batch and the Focus FMG 2022 comprehensive batch. And we have free tests available on the Unacademy app. They are educator curated subject-wise tests as well as integrated tests. And we also have the 2023 batch, which is in the form of integrated system-wise batch. This is the NEET PG subscription plan, and if you guys would like to try out Unacademy even for a month, I would highly recommend you to use my code Dr.Jhanvi Live, which will give you an extra discount on your subscription. So without much further ado, let's begin with our class for today. So before we begin with identifying what is this instrument that I'm showing you, first we'll do the anatomy of the kidney and the questions that come from it. Okay, so the first thing that I want to ask you guys in anatomy of the kidney, as all of you all know, you have to first tell me what is the arterial supply, you have to tell me what is the venous drainage. This is what we always start off with, because these are one-liner questions that are asked in the exam, and most of you all will not focus on this. You all will directly go to the pathology part. So jaldi tell me what is the arterial supply, what is the venous drainage, what is the nerve supply, and what is the lymphatic supply of the kidney. Teja Kumar Folies को भूल जाओ for now. Okay, so where is the arterial supply of the kidney coming from? Can anyone tell me? Very easy, yaar. Okay, so it comes from the renal artery, barabar. And where does the renal artery arise from? Left and right renal artery, both of them arise from the aorta, correct? What about the venous drainage? Venous drainage also very easy. It comes from the renal vein. So Now you have to know a little bit about the renal vein, because this is one of the questions that they ask in the exam. So you have to tell me which renal vein is longer, the left renal vein or the right renal vein is longer. Also, you need to know that the right renal vein is just drains the kidney and the adrenals. Okay. Your left renal vein is joined by the left ovarian or the left testicular vein and the left inferior phrenic vein. And finally, all of these end up draining in the IVC. Okay. So this is how you need to remember the, yeah. So what is longer? Your left sided renal vein is much longer as compared to your right sided renal vein. So you can remember ki left renal vein mein everything is happening. It is joining the other veins of the body. It is also longer than the right renal vein. So left renal vein is important. Right renal vein is simple. Okay. Now, what is the nervous supply of the kidney? Anyone? Which segments of the thoracolumbar spine will be supplying the kidney? Yes, angle का भी कुछ फंडा होता है. Absolutely correct, छोले भटूरे. So what they say is that from the renal artery arises from the aorta at right angles at the level of the L1 and L2 vertebra. Okay, so if you're talking about, this is the aorta and this is the renal artery. The renal artery arises at an angle of 90 degrees. Okay. Yes. So the nervous supply is from the segments T10, T11 and T12. Okay. So T10, T11, T12, this is the spinal segments supplying the kidney, and the lymphatics will drain into what? Now the kidney is right in front of the aorta, correct? So where will the lymphatics drain into? There are para-aortic lymph nodes. Okay. So the kidney will eventually end up draining into the para-aortic lymph nodes. So these are the basics about the kidney that you need to know from point of view of anatomy, because kabhi surgery mein they will also ask you these questions. Okay. Now let's move on to one of the most important instruments in urology that they ask. I am asking you everything, not just the pathology part, but also a little bit of instruments and also a little bit of anatomy, also a little bit of physiology, because sab kuch aane wala hai exam mein. Okay. So you cannot predict what will come. So this is the Foley's catheter, absolutely correct. Now Foley's catheter was founded by someone called as Frederick Eugene Foley. He was an American urologist. Okay, you have to tell me what is the material that a Foley's catheter, normal Foley's catheter that we use day in and day out, is made up of. Okay. Second thing that you have to tell me is, how is the Foley's catheter made self-retainable? What do you mean by self-retainable? How does it stay inside the bladder? How does it not come out of the bladder? How does it not slip out of the bladder? Okay. The next thing you have to tell me is the duration for which a Foley's catheter is kept and the sterilization of a Foley's. And then we'll go to the sizes in adults and in children. Okay. Chalo, sab batao. Very good. Manali, Teja Kumar, Chole Bature, absolutely correct. So the material that the Foley's catheter is made up of is latex. How is it made self-retainable? You have a balloon, correct? You have a balloon which you fill with distilled water. Please remember this, guys. This is important for the exam. What do you fill the balloon with? Many of you all say normal saline or mark as normal saline in the exam, but the ideal solution to fill the balloon with is distilled water. Okay. Now, how much time can you keep it for? Very good, Teja Kumar. So you can keep a Foley's catheter for 7 days. And how do you sterilize it? Sterilization of the Foley's catheter? No, we are talking about the latex Foley's catheter only right now. We are not talking about the silicone catheter. Alright, so sterilization, I'll tell you, it is done with gamma radiation. Okay, sterilization is done with gamma radiation. Anyone, tell me the sizes of the Foley's catheter that we use. Okay, Chole bhature, you're saying it is single use. I am talking about before use. Okay, so you'll make the entire Foley's catheter out of latex. After that, you have to sterilize it. Remember, have you all put Foley's in the hospitals? You all have to make sure you're wearing sterile gloves, and you have to sterilize. You have to clean the area very well at the urethra, and then you remove it in a sterile manner and you put it. So it is already in a sterile packet. So how do you sterilize it and put it in a sterile packet? By doing gamma radiation. Okay. Obviously, it is single use. The minute you remove it from the patient, you throw it away. All right. So I don't want this range of Foley's catheter sizes. So in adults, most commonly we use the 16 French Foley's catheter, and in children, most commonly we use the 8 to 10 French Foley's catheter. This is what you need to remember, because yes, color coding भी होता है size के हिसाब से. Absolutely correct. You have orange color, which will be your 18 gauge Foley's, 18 French Foley's catheter, but you don't need to remember the color coding for now. Only this much is enough. All right. Now, next thing you need to tell me, what are your uses of Foley's catheter? Give me 1 or 2 uses and complications, and that's it. बताओ, एक दो uses बताओ. Where do we use the Foley's catheter normally? Everyone must be like, मैम is starting from very basic topic, ये तो हम पढ़ लेंगे, लेकिन ये सब ना याद नहीं रहते हैं, एग्जाम में आ जाता है कि how much time do you keep the catheter for, what is the material it is made up of, what are the sizes, what is the sterilization, and ये सब one liners में then you all get the answer wrong. Okay, so you need to even know a little bit of the basics. Okay, so Foley's catheter basically used in two cases mainly. One is whenever there is retention of urine. Okay, so if the patient is not able to pass urine on his own, so you will have to drain the urinary bladder. Okay, so in case of benign prostatic hypertrophy, most commonly you have retention of urine. Second is if the patient is very sick and you want to measure the urine output. Okay, so urine output measurement, how do? You connect this Foley's catheter to a urine bag and you make sure that you count hourly or measure hourly urine output and see. All right. Next, the complications that occur in Foley's catheter. I will give you a little bit of an idea about the complication. So you can get infection. You can get, if you put it very forcibly, you can even get hemorrhage, and you can get stricture formation if you keep it for a long period of time. So these are the usual things. You will be able to identify this or answer these in the exam. Now what you have to tell me is how long is the silicone catheter kept. Everyone knows if you want to keep it for a longer period of time, you can put in a silicone Foley's, correct? So what is the duration, maximum duration up to which you can keep a silicone catheter? UTI, very good. इधर UTI infection में हो गया. Block भी हो सकता है. There can be a blockage of the catheter. So tell me, how long can we keep a silicone catheter? Fairs is saying 30 days, Chole Bhature is saying 1 month. Very good, Pramod. So maximum of 3 months. You can keep a Foley's catheter up to a maximum of 3 months. Alright. So remember this answer. Alright. Now moving on to our next topic. So can you see this and tell me what is the name of this catheter and where do we use it? Okay, so just look at the end of this. This end looks like a flower shaped end or an umbrella shaped end. Okay, will this actually go into a normal urethra of a male? Will this go into a urethra of a male or a female? No, this is not going to go into a urethra. So this is called as Malecot's catheter. Okay, this is Malecot's catheter, and this is not used for normal per urethral catheterization. But what is it used for then? It is used for suprapubic cystostomy. All right. So if you want to, in a patient who has had a bladder trauma, or in a patient where there is per urethral some problem, there is a stricture or something, you can use SPC or suprapubic cystostomy. All right. So in that we use this Malecot's catheter. So a few questions that they ask sometimes about Malecot's catheter. You have to know the material that the Malecot's catheter is made up of and how do you sterilize it. And please remember, this is never used per urethral. Okay, so the use is for suprapubic cystostomy. So what is the material it is made up of? Anyone? Very good. It is not made up of silicone. Absolutely wrong answer. Jaldi jaldi batao, because we have a lot to cover. No latex. Okay, it is made up of red rubber. Okay, and how do you sterilize this? This is a very simple catheter. So you sterilize it by boiling. Use, I told you, it is used for suprapubic catheterization. Okay, and finally, what is the duration for which we use it? So we use it for 3 months. Okay, we can use it for up to 3 months. The only disadvantage of this catheter is that you are putting it into the suprapubic area. Okay, so you have to do an open surgery. You have to open the bladder and then you have to put the Malecot's catheter. All right. Okay. Now moving on to our next. Now let's start moving on a little bit to the important pathological topics in surgery related to uro. Okay. So this is the first specimen we have. Can anyone identify this specimen for me and tell me what exactly are we talking about over here? Very good. So everyone can see over here that the kidney is joined from the lower pole. Absolutely. So this is nothing but a horseshoe kidney. Absolutely correct. This is horseshoe kidney. Okay. So now let's discuss a little bit about horseshoe kidney and the questions that are asked in it. So the first question that they will ask is this more, now they will always ask you questions like all of these are true about horseshoe kidney except, so you need to know each and every point about horseshoe kidney. So tell me whether it is more common in males or in females. Second question, tell me the fusion of which pole is more common, lower pole or upper pole. Fusion of which pole is more common. Okay, so in this picture you can see that the lower pole is fused, but you also can have upper pole fusion. So what is more common? Next thing you have to tell me is where is the most common site of fusion, as in related to the lumbar vertebra. In front of which lumbar vertebra will you find the isthmus? This bridge that is formed now, this is called as the isthmus. So this isthmus is found in front of which lumbar vertebra? Okay. Second thing you have to, okay, next thing you have to tell me is the clinical features of this patient. So how will this patient present and how will you diagnose? So quickly tell me all of these answers. More common in male or female? First of all, males may more common, absolutely correct. Lower pole, absolutely correct. So lower pole fusion is more common than upper pole. Most common site of fusion, very good, in front of L4 vertebra, fourth lumbar vertebra, L4 vertebra. Clinical features, patient will present with features, not L3, L4, just remember a single one, L4, okay. Clinical features that the patient will present with, yeah. So most of the times the patient is asymptomatic. Usko pata nahi chalta hai that he has some problem. But what kind of presentation will the patient have? He will come to you with recurrent stones. That is the one thing. So recurrent stones and recurrent UTI. So you will wonder why is he having this problem, and then you will order some tests for diagnosis. So what is the test that is shown in the picture over here? The radiological test shown in the picture. Can anyone identify it? So one thing you can do, simple bedside test, is you can do an ultrasound abdomen. Okay. But ultrasound abdomen, kidney being retroperitoneal in nature, will not give you a very good picture of the isthmus. Okay. So the best test that you can do is something that is shown in the picture. What is the name of this test? IVU. Very good, Rishikulis. So this is called as intravenous urography. Okay. So what is the appearance that you see in the IVU? यहाँ पे कैसे दिख रहा है? ये देखो, यहाँ पे यूरेटर है, यहाँ पे यूरेटर है, and then this part will be joined together like this. So that's how you can see in the IVU. So how does this look like? What is the appearance on IVU in case of horseshoe kidney, guys? Naam batao of the appearance. So this is called as flower vase appearance. This is what is asked in the exam. So you should know 100%. These specific words that are there, na, These are the ones that they will ask you in the exam. Okay, so it is called as flower vase appearance. It is also called as shaking hand sign. Absolutely correct. I'll write it over here. So it is also called as shaking hand sign or flower vase appearance. Okay. Alright, so everything about horseshoe kidney that will be asked in the exam. Now, other than this, they will ask you what is the treatment. Now, in the treatment, per se, you are not supposed to do hysterectomy unless there is some indication for it, okay? But whatever is the complication that is occurring, you're having UTI, treated with antibiotics. You're having stones, you can do a cystoscopic removal of the stones, if the stones, or you can use lithotripsy and remove the stones. Okay, so you're supposed to just treat the complications, and the main uh, hysterectomy is not really done. All right, so with that, moving on to our next picture. So identify this condition and tell me, what do you see? Conservative management, treat the complications. Okay, very good. So what is this? This is nothing but polycystic kidney disease. Absolutely correct. Polycystic kidney disease. Okay, so first thing that tell me, what is the most common genetic inheritance in case of polycystic kidney disease? Okay, then tell me whether it is unilateral or bilateral in nature, and what is the most common age group in which you will get the polycystic kidney disease. Then you have to tell me in which other organs will you have associated disease. Which other organs have associated cysts? There are two other organs that you need to know, three other organs that you need to know for sure. And the what is the content of these cysts? Those are the first few questions that you should tell me about. Okay, so genetic mode of inheritance will be autosomal dominant. Is it unilateral or bilateral? Very good. It is bilateral in nature. It is hardly ever unilateral. If you see a unilateral polycystic kidney, over the next few years, the other one will also start developing cysts. So in children, sometimes you will see that one kidney has cysts and the other one starts developing after a few years. Okay. What is the most common age group for presentation? Very good, Manali. So most common age group is the third decade. Okay, so in the age of 30s, they will start showing symptoms. The cyst will start forming pele only, but the symptoms will come in third decade. What are the organs which have associated cysts? Very good. Most common organ with associated cysts is the liver. So you will see hepatic cysts, and because of that, you will also have abdominal distension because of hepatomegaly. Okay, and abdominal pain can also be present. The second one that you have is pancreas, and the third you can have cysts in the lungs. Okay, and one more area where you have cysts. Anyone? One more place where you have cysts, and those cysts are very specific. Brain में. Batao, what is the name in the brain? So you get berry aneurysms in the circle of Willis in the brain. Okay, so this is nothing but cysts of the vascular nature. So berry aneurysm in the circle of Willis. Okay, yeah. Then uske baad you have to tell me what is the content of the cyst. Content of the cyst, anyone? Alright, so content of the cyst will be nothing but you will have a brownish fluid that will be the content. अभी इसमें भी तुमको दिखाई दे रहा है in this picture over here you have brownish blackish fluid. So this color comes from the hemorrhage. Okay, because there will be small vessels which will keep breaking down, and because of the hemorrhage you will get this appearance. Okay, now how will a patient present in the third decade and you will identify it as polycystic kidney disease? What are the clinical features that a patient will present with? First thing you have to tell me what is the most common presentation overall and the most common sign. Batao. Most commons are very important. Huh? Very good, Sham. So the most common presentation is patient will come with hypertension. In almost 75% of the patients will come with Hypertension. You will think this guy is just 30 years old. Why is he having a BP of 200 by 120? So first you will start treating him for essential hypertension. You will say stress, yoga, stress relief, yoga, sleep, all that. And then when you start checking everything, you will realize that there is a problem in the kidney. Okay. So hypertension is the most common presentation. What is the most common size? Okay, Chole Bhature, you have given me four presentations: hematuria, lump, uric acid stone, and pain. You're absolutely correct. Out of those four things that you've given me, tell me which is the most common sign that you see in this case. सबको पता है that if there is presence of a polycystic kidney disease, you will have a palpable mass, you will have pain, you will have hematuria. But what is the most common? Pain is not the most common sign. The most common sign is hematuria. Okay, so hematuria is the most common sign. Most of the time, the pain occurs only when the kidneys have enlarged so much that it's stretching the renal cyst. Okay, or if there is some hemorrhage into the cyst, that is the only time you have the pain. So pain is not a very common presentation. Okay, that name Chole Bhature is making me hungry. It's making me hungry also. Okay. So next question, how do you investigate a patient of polycystic kidney disease? So first one, obviously if the patient presents with hypertension, refractory hypertension, which is not responding to your medications, you will ask to do a USG KUB, kidney urinary bladder KUB. Okay, so here you will be able to see the cyst. Any other investigation? IVU में क्या appearance दिखता है? Okay, IVU में क्या दिखाई देता है? There is a peculiar name, like how we had flower vase appearance. Just like that, here also we have a peculiar name. Okay, so यहाँ पे your kidney is full of cysts, ठीक है? और फिर यहाँ से the ureter comes out like this. So kidney full of cysts and ureter coming out like this. This looks sort of the ureters look very thin and like the legs of a spider. Okay, coming out from the main body. So this is also called as spider leg appearance. Spider leg appearance. All right. So spider leg appearance is the appearance on IVU. Okay. So where will you see flower vase pattern? Where will you see flower vase pattern and where will you see spider leg appearance? Anyone? Okay. Just remember both of those. They are important. All right. Please stop talking amongst yourselves, guys, because that also causes a lot of distraction to me, because I'm trying to read your comments for the answers and I am getting your comments about food now. All right. So what is the treatment? Treatment is conservative. You don't really need to treat the patient unless the complications arise. Okay. So what are the complications that can happen? You can have continuous pain. You can have hemorrhage of the cysts. Okay. And you can also have recurrent infections. So if all these complications arise, you have to take the patient up for surgery. And what is the name of the surgery? Anyone? Very good, Sham. So the name of the surgery is nothing but Rovsing's operation. Rovsing's operation. All right. So what do you do in Rovsing's operation? You do nothing but de-roofing of the cysts and you empty the contents that are present over. Okay. So de-roofing of cysts and empty the contents of the cyst. All right. So that is what we can do. You can also do a USG guided aspiration of the cyst, but that is the one that is not asked in the exam. In the exam, they will ask you specific names. All right. So horseshoe kidney ke liye remember flower vase appearance. For polycystic kidney disease, remember spider leg appearance, and treatment ke liye remember Rovsing's surgery. All right. Okay. So with that, we've completed everything about polycystic kidney disease. Now moving on to our next picture. This is a little more complicated than what I showed you before. Polycystic and horseshoe were very easy to diagnose. This one, try to identify if you can. Yeah, Teja Kumar, absolutely correct. Renal transplantation is the best choice that is available. However, getting a renal transplant itself is not very easy. Okay? And since this is surgery, they will ask you the surgery names that are associated with the peculiar pathologies. Okay, so what can you see over here? Very good. Chole Bhature and Teja Kumar, absolutely correct. So here in the first picture, you are having two ureters over here, correct? So in the first picture, you are having duplication of ureter. What are you having in the second picture? Okay, in the second picture you are having duplication of the renal pelvis. Okay, so can you see you have one renal pelvis over here and one renal pelvis over here. So here you are having duplication of the renal pelvis. So this is how you need to identify both of them. I know the first picture most of you all were able to diagnose, but the second picture is a little more complicated. Okay, now can you guys tell me why am I showing you this anomaly? पहले तुम लोग ने कभी पढ़ा भी नहीं होगा सर्जरी में ये, so why am I showing you guys? Okay, so remember this is the most common congenital anomaly of the urinary tract. If they ask you in the exam what is the most common congenital anomaly, don't mark as horseshoe kidney. This is the one, duplication of renal ureter or duplication of renal pelvis. Okay, most common congenital anomaly of the upper urinary tract. Okay, next question that they will ask you in the exam is which side duplication is more common. So when we are talking about duplication of the ureter, which side duplication is more common? Okay, then you have to tell me what is the investigation of choice in this case and what is the treatment. Simple questions. The first question that I told you is the one that usually comes in the exam. Okay, so most common congenital anomaly of the upper urinary tract. Which side is more common? Anyone? No one has written. Right side. Sham is saying right side. Teja is saying right side. Pramod is saying left side. No, that's not correct. The left side is more common. Okay, so duplication of the left side is more common. What is the investigation of choice? CT urography. Okay. Dekho, since so long we have been doing what? We have been doing the IVU. Alright, so the IVU will give you a contrast enhanced image, and that is one of the best investigations that will help you diagnose. Okay, so CT, unless you use contrast, will not give you a very good image of the kidneys. IVU is supposed to be diagnostic for this case. Alright, okay, so what is the sign that you will see in case of IVU? अच्छा, मनाली ने लिखा था लेफ्ट साइड. ओके, मनाली और राइट. ऑलराइट, okay, absolutely correct. So in IVU you will see the drooping lily sign. Okay, you will see the drooping lily sign in IVU. And can anyone tell me what is the treatment? So you can do other investigations also to diagnose this. Okay, so obviously if you want a bedside investigation, ultrasonography will help you diagnose anything about the kidney. Then if you want to look at the ureters, if you want to look at the lower half of the ureters, you can even do a cystoscopy. So when you do a cystoscopy from the bladder opening of the ureters also, you will be able to see क्या दिखेगा. If this is the bladder you will see on one side you have a single ureteric opening, but on the other side you have a double ureteric opening. So this is what you will be able to see on cystoscopy. And you can next thing you can also do is the treatment. So what is the treatment done? So most of the times ये सब में कुछ भी नहीं treatment करना होता है. You do a conservative management only. Okay, what is the problem? The problem is when the opening of the ureter develops a stricture. Opening of any one or both the ureters develops a stricture. So if there is narrowing of the opening, that is called as the ureteric meatus, you will do a ureteric meatotomy. Ureteric meatotomy. Okay, so that will help in enlarging the size of the ureteric opening. Okay, yes, absolutely correct. Okay, now moving on to our next picture. So this is very easy to diagnose. One of the most easiest to diagnose. But you're looking at the IVU image also, you're looking at the gross image also, and what is the thing you can see? You can see this side the ureter is absolutely normal, this side the ureter is distended, and also there is something in the bladder on this side. Yes, absolutely correct. So this is called as cobra head sign, this or adder head sign. Okay, this is called as adder head sign on IVU or cobra head sign. And this is seen in which case? This is seen in ureterocele. Okay, so this is ureterocele. What is ureterocele? It is nothing but a cystic enlargement of which portion of the ureter. You have to be very specific in this because this is asked in the exam. You can see the cystic enlargement over here. It is a cystic enlargement of the intramural portion of the ureter. Intramural means the portion of the ureter which is inside the bladder musculature. Okay. All right. Chole Bhature is asking for a request. Clagot-Mayer law bata do. Okay, Chole Bhature, it is not Clagot-Mayer law, but it is called as Weigert-Mayer law. Okay, it is called as Weigert-Mayer law. I'll just tell you guys that before we move ahead. So in duplication of renal ureter, you have something called as the Weigert-Mayer law. What does the Weigert-Mayer law say? So the Weigert-Mayer law says that the double ureter that you have now, it can be a partial double ureter. What do you mean by a partial double ureter? If you have the ureters, upar se to there are two ureters which are coming, but in the lower part they join and they form a single ureter and they have a single opening here in the bladder. Okay, so that is when you call it as a partial double ureter. When do you call it as a complete double ureter? Complete double ureter is what you can see in the picture over here. You have two ureters coming. One is opening over here above and one is opening over here below. Okay, so they have two separate openings that are present in the bladder. Okay, so that is called as, because completely throughout their entire length they are present separately as two ureters. So that is called as the Weigert-Mayer law, in which you call it as a partial double ureter or a complete double ureter depending on whether they are opening separately or together in the urinary bladder. समझ में आ गया? Weigert-Mayer law. Okay. that is associated with the duplication of renal ureter. All right. So don't think guys I'm not reading your comments. That's why I'm saying that you all write little more relevant comments so that I don't have to find for your questions over there. Okay, so now let's move on to the next thing that we were discussing. So this is adder head sign, or this looks like a cobra head or an adder head, which you see it in ureterocele. ठीक है? So ureterocele in किस में ज़्यादा common होता है, in males or in females? Any idea? It's a congenital problem. Okay, it's a congenital cystic enlargement. It is more common in females and it can occur bilaterally also in very few cases. How will you know that a patient is presenting with ureterocele? How will you come up with the idea of doing the IVU? So same, patient will present with recurrent stones, patient will present with recurrent infections, and he'll also present with presence of hydronephrosis. So when this is happening again and again and the patient is recurrently visiting the urologist, he will get all the tests done. So on doing an IVU, he will be able to see the cobra head appearance. Okay. All right. Okay. So isme now, if you want to remember, there is a classification that comes in ureterocele and that is called as the Stephen classification. Stephen classification. Okay, so Stephen classification mein what do they discuss? They discuss how does this cystic enlargement look, whether it is a stenotic enlargement, sphincteric enlargement. You don't need to know the details of it. You can just remember for your exam because it may come as a one liner that Stephen classification is given in case of ureterocele. Okay, इतना detail में मत जाओ, इतना जितना मैंने बताया that much is only enough. Okay, all right. What is the treatment? Anyone? What is the surgery that is done in case of this? Or you don't do anything? As usual, whatever is the complication, stone, UTI has to be treated. Anything else that is done? Yeah. So what happens is, if this is your bladder, correct? and this is where the cystic enlargement is present on this side. This side is a normal opening. This side is the cystic enlargement. So if the cystic enlargement is abnormal and the urine is not draining easily into the cystic enlargement, then what do? You simply remove the cyst wall. The cyst wall needs to be removed and you do a meatotomy. Okay. So what will you do over here? Meatotomy plus cyst wall removal. So that will help you in draining the urine back from the normal ureteric opening. All right. So that is your treatment for cystocele. Okay. Okay. Moving on to our next topic now. Okay. So I know I have given you all over here what is the pathology. Can anyone read for me what is the pathology that we are going to discuss next? Okay, so this is nothing but renal TB. Okay, this is a gross pathology of a specimen of renal TB. Okay, so the questions asked about renal TB are very simple. They will ask you in the kidney. Most commonly, will you have primary or secondary TB? Okay, if it is secondary TB, where is the primary source coming from? Where is the spread of the TB bacilli occurring from? Okay, then next thing you have to tell me about renal TB is basically what are the clinical features that the patient of renal TB will present with. Okay. TB हो गया. Okay. Alright, so you have to tell me what is the clinical features that the patient will present with, because they are something which are very, very specific. Then we'll discuss the investigations that you will do in a patient of renal TB and what is the treatment. Treatment तो बहुत easy है. Everyone knows the treatment. Okay. So tell me from the first, is it primary or secondary? In renal TB, the kidney is getting tuberculous bacilli directly, or it is getting it from the hematogenous route from somewhere else. No one is answering. Very good. So it is always a secondary infection. And where is the primary source if you are having this as a secondary infection? Yeah, so the primary source comes from the lung most commonly. Okay, what are the clinical features that the patient will present with? So remember that the patient will present with features of UTI. He'll present like he has a urinary tract infection. Okay, so he will have increased frequency of urine. Day and night, he will keep going to the bathroom all the time. And every time he goes to the bathroom also, he passes a large amount of urine. So there is polyuria. Okay, then after that, okay, छोले भटूरे I don't, आपने comment section लग करा है means छोले भटूरे, what is your question? I don't understand. Okay, so there will always be increased frequency of urination. There will always be more polyuria. Then the next thing you get, which is very characteristic of this disease, is you get sterile pyuria. Okay, so you will be able to see that there are pus cells in the urine. So there will be almost 30 to 50 pus cells per high power field. So easily on urine examination, pus cells will be found. But if you go to look at the organism, you will not find any organism. Okay. So you have to do acid fast staining to be able to see the TB bacilli. Alright. So pus cells present, organism absent. This is called as sterile pyuria. Okay. Then sometimes the patient may also present with hematuria. But this hematuria will be microscopic in nature. You will not be able to see it with the naked eye. It won't be gross hematuria. Okay. So these are all the symptoms that the patient will present with. Other than this, normal TB symptoms that are there, fever, weight loss, all that will also be present. Okay. So this is how a patient presents. Now tell me, in this condition, the kidney will have the pus present in it. So that caseous kidney also has a name in renal TB. Any idea what is the name? Yes, very good, chole bhature. So it is patti kidney, or it is also known as cement kidney. Okay, appearance of that caseous material in the kidney is called as putty kidney or caseous cement kidney. All right. Then can you tell me which side is affected more? Right side is affected more or left side is affected more? Right side is affected more or left side is affected more? Alright. Then we'll move on to the investigations till you guys answer that question. So investigations may first in TB you always have to do CBC. In CBC you will always see the patient has anemia and he has a raise in the ESR. Okay. Then to look for the primary, you have to look for the primary source mostly in the lung, so you can do a chest X-ray. Okay. Then you have to look whether the kidney is affected or not. So if the kidney is affected or not, you will look for it in the urine. Correct. So you will take urine samples for 3 days. Remember this, you have to take urine samples for 3 consecutive days and you will send it for ZN staining. I told you na, in normal sampling you will not be able to find the TB bacilli, but you can do a ZN staining in which you will be able to find the TB bacilli. Okay, so 3 continuous day samples you can send for ZN staining. Then if you want to grow a culture, you can grow the culture on the LJ medium that is used for TB. And the next thing that you can do is you can also do a CT scan of the kidney or a X-ray of the KUB region, which will show you the cement kidney or the calcified kidney or the putty kidney. Okay. So these are the specific investigations that you will see. There are 2 more things. Someone has already mentioned it over here. Okay. Yeah. So first of all, ये किसी ने बताया नहीं मुझे. Pramod is saying left side is more common. Okay, so that is wrong. The right side kidney is affected more commonly as compared to the left side kidney in TB. All right, in TB of the kidney. Okay. Then the next thing that you will see is you can also see golf hole ureter. Okay, so your ureter will show you dilatation, and that is why this is called as golf hole ureter. And what do you see in the bladder? The bladder is also quite irritable, and this is called as the thimble bladder. Okay, so both of these things, just like we had flower vase appearance and we had the other appearances for polycystic kidney disease में क्या था appearance? We had drooping lily sign, then we had one more sign, correct? Polycystic का क्या था? मैं ही भूल गई. याद करो, मुझे बताओ. Okay, so that just like you have it over there, we also have the specific names for TB of the kidney. So thimble bladder because of continuous irritation of the bladder, and golf hole ureter because of the edema or the swelling around the ureteric orifice and enlargement of the ureteric orifice. Okay, so that is why you have the appearances that are important for the exam. All right, then what is the treatment in this case? Anyone? Treatment, yeah, spider leg appearance was there in case of polycystic kidney disease. Good. Absolutely correct. So the treatment will be nothing but anti-cox therapy. Okay, so you have to give anti-cox therapy, but what is the duration for anti-cox therapy in case of kidney disease, in case of TB kidney? Batao, duration of ATT. Will you just give it for 6 months? Will you give it for a longer period of time? Yes, very good, Manali. So you will give it for 1 year. Okay. So ATT for kidney TB is for 1 year. Okay. So everything about kidney TB has been discussed. How does it look? What is the most common presenting feature? What are the appearances? Which side is affected more? What are the investigations? What are the specific signs that you need to look in TB of the kidney, and what is the treatment? Okay. Alright. So moving on to our next topic now. Can you guys identify what is our next topic? क्या हो रहा है यहाँ पे? grade 1, grade 2, grade 3, grade 4 is given of what? Okay, very good. So this is nothing but hydronephrosis. Okay, this is hydronephrosis. So what are you seeing in hydronephrosis over here? You can see dilatation of the pelvic alveolar system. All right. So now let's have a look at some causes of hydronephrosis. So hydronephrosis can be either unilateral or it can be bilateral. So give me 3 causes of unilateral and 3 causes of bilateral. 3 causes of unilateral, 3 causes of bilateral. Anyone? I'll start helping you out, guys. Okay. So in unilateral causes, there could be compression of the pelviureteric junction. So where will the compression come from? It can come from any kind of growth. So it can come from a cancer. Okay. Then second, the compression can come from any aberrant vessel. Okay. Or the compression can come from any kind of abnormal ureter or kink in the ureter which is compressing on the flow of urine. Okay. Then other thing that you can have, yes, you can also have obstruction. So obstruction unilaterally can happen because of presence of a stone, barabar, or presence of a ureterocele. We saw now before cobra head appearance or adder head appearance, that is seen in case of ureterocele. ठीक है? Alright. Bilateral में क्या होगा? Anyone, can you give me 1 or 2 causes of bilateral hydronephrosis? That means there has to be most commonly some problem in the bladder. Okay. So only if there is some problem in the bladder, both the ureters will be dilated in nature. Both the ureters will get dilated, and that's when you will get bilateral hydronephrosis. Alright. So can you give me any examples from what I've told you? Very good. Benign prostatic hypertrophy. Look for more distal obstructions. So prostate is one. Second, maybe because of just like benign prostatic hypertrophy, you can even have malignancy of the prostate. So you can also have CA prostate. Okay. And you can have anything in the bladder, psychoureteric reflux. Very good. All right. So these are all are unilateral or bilateral. There are more causes also, but you can, these are the common causes of unilateral and bilateral hydronephrosis. Okay. Now, what will they ask you in the exam? They'll ask you the clinical features, or they'll give you a case scenario of a patient coming with hydronephrosis. So can you tell me how will a patient of hydronephrosis present? Will there be any obvious symptoms, or it will just be incidental finding? Imagine the kidney is enlarging in size. So if the kidney is enlarging in size, what will it do? It will also press on the capsule of the kidney. So if it extends or it distends the capsule of the kidney, you will have pain. Okay. So the patient will always present with dull aching loin pain because of stretching of the capsule. Okay. And he will also feel heaviness in that area. Dull aching loin pain and heaviness in the area. All right. Anything else that the patient will present with? Okay. So when you palpate the that area, patient will say यहाँ पे बहुत दर्द होता है doctor, there is a lot of pain. So when you palpate, because of the distended kidney, you will be able to feel a mass in the loin, and this mass in the loin is smooth and it is easily palpable. It moves with respiration, so you can palpate it very easily. Okay. Then the patient will also present with Dittle's crisis. Can anyone tell me what is Dittle's crisis? This is something which is very important for this topic. Dittle's crisis में क्या होता है guys? Yes, so Dittle's crisis में क्या होता है? First, the patient will have loin pain. He will say, I have excessive pain in my loin. Okay. After that, suddenly the swelling that was there in the loin, it will disappear. Okay. And when the swelling that is there in the loin disappears, within 10 to 15 minutes, you will see that the patient passes a large volume of urine. Okay, so that hydronephrosis is getting resolved. Okay, so that is called as Little's crisis. First, patient will present with loin pain. Then he will see, suddenly you will see the swelling in the loin has decreased, and after 10 minutes of the swelling in the loin getting decreased, patient will pass large amount of urine. Okay, so that is what we see in case of Little's crisis. Okay, now how do you investigate this hydronephrosis? Anyone? Investigation of hydronephrosis? Very easy to investigate. Anything in which the kidney size has enlarged, the kidney is dilated, can actually be picked up by any of the investigations. Okay, very good. You can identify it easily on ultrasonography. Because why? Because the pelvis of the kidney is distended with the urine. Okay, so this acts as a good medium for echogenicity of the ultrasound. So you will be able to find the distended kidney and the distended renal pelvis very well on ultrasonography. Okay, anything else that you can do? Some more formal and better investigations, you can do a CT scan. CT scan can help you diagnose it. Okay, you can also do an IVU. Okay, so in an IVU, if you look at the normal callisis, they will have a nice pattern like this. Okay, but in case of hydronephrosis, you see that there is effacement of the callisis, so they actually become rounded and distended like this, and they lose their normal pattern. Okay, so that is all that you can all the ways that you can diagnose a hydronephrosis. Okay, what is the treatment? Anyone? Okay, so all of you are saying DTPA. Now, DTPA will not help you diagnose the condition. It is not going to give you a picture of what is wrong with the kidney, but it will tell you about the functioning of the kidney. Okay, so in all of these conditions, polycystic kidney, horseshoe kidney, hydronephrosis, duplication of renal pelvis, all of them, the renal parameters will be a little deranged, the renal functioning will be a little less. So in order to check the renal functioning, what you can best do is do a DTPA scan. Okay, all right. Okay, what is the treatment? Absolutely correct. So you have to treat the cause. So suppose you have some growth which is compressing, so you will debulk the growth. If there is an aberrant vessel, you will ligate the aberrant vessel. If there is an abnormal ureter, you will treat it accordingly. If there's a stone, you will have to do a stone removal, ureteroscopic removal, or you can do lithotripsy. Benign prostatic hypertrophy or CA prostate may, you will do a prostatectomy. Okay, so you have to treat according to the cause. So that is the treatment. Treat the cause. Okay, now there is another surgery that is done in case of whenever you have this disease. So that is, you just need to know the name of the surgery. You don't need to go much into its details. It is called as the Anderson-Hines operation. I'll just write it over here. Anyone know this surgery or heard of this surgery? Only if they ask sometime in the exam, Anderson-Hines operation is operated with is associated with which disease? So then in that case, you can mark the answer that it is associated with hydronephrosis. Okay. So what happens if there is a pelviureteric junction obstruction since a long period of time? Okay. So what happens? The pelvis that is there, renal pelvis that is there, this becomes completely spasmodic, fibrosed and redundant. Okay. So what you do is that you excise this, you remove it, and you create a new pelvis. Okay, so what are you doing? You're doing a pyeloplasty. You're creating a new pelvis. So this is called as Anderson-Hines operation. Okay. Okay. Guys, if you all talk about things that are going to distract me during the class, that is only going to waste your time as well as my time. I'm not here to engage in banter with you guys, but I'm here to teach you all. So please maintain the decorum of the class. All right. Moving on to our next disease. So identify this condition. So you can see the kidney, you can see the renal capsule, in the perinephric fat area, you can see presence of an abscess. Okay, so this is where the abscess is present. So what is this called as? Is this pyonephrosis? Anyone? Will you classify this as pyonephrosis? Anyone? No. So this is not pyonephrosis. See where the abscess is present exactly. You can see the kidney, you can see the capsule. Okay, so this is present outside the kidney. So this is called as a perinephric abscess. Perinephric abscess. Okay, for pyonephrosis, the pus needs to be there in the kidney. Okay, so now let's discuss pyonephrosis. So don't get confused between all this. So in pyonephrosis, where will your infection be or where will your pus be? So if this is your pelvic ileal system, okay, this is your pelvic ileal system. So your pus needs to be here in the pelvic ileal system. Alright, so this is when you call it as pyonephrosis. Now, when do you get pyonephrosis? They'll ask you of a few related causes. So if the patient has had acute pyelonephritis, so your kidney will be full of pus. The second thing is if he has pre-existing hydronephrosis. So there can be a super added infection. So in that case, it is called as pyonephrosis. Correct? Then there is a triad of presentation. So can anyone tell me the 3 important symptoms that the patient will present with? Symptoms and signs. What is the triad of presentation in case of pyonephrosis? Okay, so I'll tell you the triad. Obviously, because you have presence of an abscess, there will be fever. Okay, there is some infection, there is some abscess, so there has to be fever. Second thing that you will get is because of the abscess, there will be relative enlargement or dilatation of the kidney. So you will feel a swelling in the loin. Okay, so there will be a loin swelling. And the third thing, because of the toxicity of the infection, you will also have anemia. Okay, so fever, anemia and loin swelling is the triad that the patient will present with. Pain will not be the presenting feature. These will be the presenting features. Okay, so how will you investigate a patient? This is so very easy. Investigation and treatment of pyonephrosis. Quantum mechanics, if you're a NEET UG student, then this class is not for your level. We are preparing for NEET PG. Okay, so can anyone tell me the investigations? Yeah, so the investigation, very simple. First of all, you will have to do a urine analysis. Okay, so in urine analysis, you will be able to find pus cells. Then you on microscopy, you can also see the organism. Okay, and if you want to culture, you can also grow the organism. Okay, so these are the 3 important things that you need to be doing. Then the next thing that you need to do is you need to do an ultrasound. So ultrasound will show you nothing but dilatation. Ultrasound cannot show you whether the dilatation is because of fluid, whether it's hydronephrosis or whether it's because of pus, pyonephrosis. How will you know that? You will have to do an ultrasound guided aspiration of the fluid, and then only you will be able to identify it as pus or as plain sterile fluid. All right. So that is how you can identify pyonephrosis. What will be the treatment? Treatment is nothing, very simple. You will start the patient on antibiotics. If it does not resolve on antibiotics, you will have to drain the pus from the kidney. Okay. So how do you drain the pus from the kidney? So suppose this is your kidney. You put something over here which is called as a nephrostomy tube. So you make an incision right above the kidney and you put a nephrostomy tube. Nephrostomy tube is open at both ends, and then you will drain it out from the nephrostomy tube. Or the other thing that you can do is you can do a suprapubic cystostomy and place a Malecot's catheter, or in the renal pelvis you can place a Malecot's catheter and drain it. Okay, so most commonly you will place a nephrostomy tube which will help in draining out all the pus, and once the pus is drained out, the patient will feel much better. Your antibiotics will also start acting better and the abscess will start resolving. Okay, all right, clear guys? Okay, so now since we have spoken about pyonephrosis, let's talk about perinephric abscess. So perinephric abscess is present outside the kidney. It is not present inside the kidney. It's not inside the pelvic alveolar system, cortex, medulla, nowhere. Outside the kidney, in between the capsule and the kidney. Okay. So what is the most common cause of a perinephric abscess? Where does it develop from? Any idea? Any idea? Common causes of perinephric abscess, guys? Okay, so one thing is you can get a TB of the perinephric abscess. Okay, so if you have tuberculosis bacilli coming from the lung or from any other primary source, it can come here and cause a perinephric abscess. Second thing is if you had a perinephric hematoma. And how does this occur? So sometimes patients get operated, correct, for stones or for any structuroplasty, anything. So after surgical involvement of the kidney, sometimes you may have a small bleeder over there. So that small bleeder may form a hematoma, and that hematoma may stay in the perinephric space and then get secondarily infected. Okay, so that is called as perinephric abscess secondary to a perinephric hematoma. Okay, or now diabetic patients also, since they are immunocompromised, commonly you will see all these infections happening in them. In fact, even pyonephrosis is quite common in diabetic patients. All right. Okay. What are the clinical features that the patient will present with? So similar to pyonephrosis, the triad of clinical features in perinephric abscess will also be very similar to pyonephrosis. Of course, there is abscess, so there will be fever. Of course, there is an abscess, so there is dilatation. So there will be a loin swelling. Okay, and what was the third thing that we saw over here? The third thing was anemia, but here you will not get anemia. In fact, because of the stretching of the renal capsule, you will get tenderness in that area. So this will present with pain. You will get tenderness and you will get guarding rigidity in that area. Okay, because of the inflammation and the swelling of the capsule, stretching of the capsule. All right. Okay, and because of the pain, the patient will walk like this towards the side of the pain. So you can also say that he will have scoliosis on side of pain. All right, so that is how you will, yeah, he'll bend towards the affected kidney. Absolutely correct. Now the next thing that we have to discuss is the investigations. So I'm just writing it down over here. Okay, there's no place over here. Okay. So for perinephric abscess, how do you identify it? How do you investigate it? So when you do a CBC, obviously there is an abscess, so your WBC count will be increased, your ESR will be high, and you will have anemia. There is an infection. Okay. Then the next thing that we can do, as always, is an ultrasound of the abdomen. Ultrasound of the abdomen will clearly show you that there is some mass that is outside the kidney. Okay, and if you want to exactly see where is the mass, then you can do a CT KUB. So the CT scan will show you the image of the kidney, and outside the kidney you will be able to identify the presence of the abscess. All right, so that is very easy that you can see. X-ray say also you can see, but you will not be able to localize the abscess very well through X-ray KUB. So CT KUB is a better option. All right. Okay, so now moving on to our next disease. Okay, so what can you guys identify over here? What can you guys identify over here? What is there in the picture that we are discussing now? Okay, so what are you able to see over here? There are presence of multiple calculi, correct? So here you are seeing a stone in the pelvis. Here you are also seeing your own stone in the upper part of the ureter. Okay, so where do all, what are we going to discuss now? We are going to discuss renal calculi. Okay, so in renal calculi, tell me a few examples of the first few things that we need to discuss is the different crystals that you find in ureteric calculi and what are the stones that they represent, or what is the composition of those crystals. Okay, so when you have dumbbell shaped crystals, what are we talking about? Dumbbell shaped crystals. Second one is envelope shaped crystals. Third one is coffin lid shaped crystals. Fourth one is hexagonal crystals. These are the common ones that occur in the exam, the ones that come in the exam. Okay, so quantum mechanics is saying calcium. Yeah, yes, very good, Pramod Kumar. So dumbbell shaped crystals are seen in calcium oxalate monohydrate stones. Okay, envelope shaped crystals will be seen in calcium oxalate dihydrate stones. Coffin lid shaped crystals will be seen in coffin lid shape will be triple phosphate stones. Hexagonal crystals are seen in, okay, yes. So hexagon, make a hexagon over here. What is the hexagon made up of? One C from this side and the other C from this side. Okay, so C say you can remember. Hexagonal shaped crystals are seen in cystine stones. All right. Okay, out of all of these stones, which is the most common type of stone? Out of all of them, which is the most common type of stone that occurs? Stagon calculus is not the most common type, Teja Kumar. Okay, so it is your calcium oxalate stones that are the most common type. Okay, so your calcium oxalate monohydrate and calcium oxalate dihydrate, they are your most common type of stones that occur. Okay, now the next thing that they will ask you in the exam is staghorn calculus is seen in which type of stones? Staghorn calculus is seen in which types of stones? So guys, if y'all are not going to maintain the community guidelines and distract everyone during the class, I have an option of blocking y'all. You won't even be able to attend the classes well then. So it is up to you guys how you want to use these classes. I think all of us are preparing for the NEET PG exam, which is upcoming in the next 1.5 months. So I highly recommend that you all pay more attention to your studies and not just wasting time. Okay, so staghorn calculus is seen in triple phosphate stones. Remember that. Okay, so what is a staghorn calculus? Very easy. If this is your kidney, staghorn calculus will be actually taking the entire space. It's a big stone taking the entire space of the renal pelvis. Okay, so it fills all the renal calyces. That's how you call it as a staghorn calculus. Okay, okay. Now some questions that they ask in the exam, very specific ones. In acidic urine, which kind of stones are formed? In acidic urine, which kind of stones are formed? Any idea? Triple phosphate? No, that's not correct. Okay, I'll give you one more example. This stone, whenever you expose it to light, it will turn greenish in color. Okay, so this is nothing but our cystine stones. Okay, cystine stones, they are found in acidic urine. They are seen in patients who have cystinuria and they turn greenish on color when you expose it to light. Okay, and remember this specific thing about cystine stones, that it's also radio opaque. Now, why is it radio opaque in color? It contains sulfur in it. Okay, so that makes it radio opaque. Okay, then next thing that they will ask you in the exam is which stone is blue color. Anyone, any idea which stones are blue color in? Very specific ones. And which stones are seen in Proteus or Klebsiella infections? Whenever you have Proteus or Klebsiella UTI, what is the stone that is seen? Okay. Comment section is lagging, yeah, a little bit, but that's okay. You guys answer. I'll wait for you all. Okay. Yeah. So blue colored stones are made up of nothing but indigo. Okay. So indigo stones are blue colored stones, and in Proteus or Klebsiella, they are nothing but urea splitting organisms. Okay. So in Proteus or Klebsiella UTI, you will see true white stones. So these are the one-liners that you need to know for your exam that come quite often. So make sure that you go through this before the exam. I always tell everyone to keep a small notebook in which you will have the things that you will tend to forget a lot. So like the shape of the crystals, then one-liners about the stones. These are the ones that you need to remember a week before the exam. All right. Okay. Now, whenever we are talking about stones, what are the common clinical features that the patient will present with? So this everyone knows. There will be pain in the loin to groin pain patient will present with, classical. Then there will be hematuria because of the stone that is scraping the ureter inside and causing bleeding. You can have pyuria if there is a secondary infection, fever if there is a secondary infection, and both of these are because of UTIs. Okay. Now, what are the investigations that you will prefer to do to determine a stone? What is the easiest, most commonly available, cheap investigation which will definitely give you the occurrence of a stone? Okay, so remember, ultrasound abdomen is one of the best investigations that you can do for finding a stone. Now, why specifically ultrasound abdomen? Even if you do an X-ray, you will be able to see a stone, correct? But most of your stones, 90% are radio opaque, but 10% of them are radiolucent. So the radiolucent stones that are there, you will not be able to see them on X-ray. That is why we prefer ultrasound, because it will be able to identify any stone, radiolucent or radio opaque, उससे कुछ फर्क नहीं पड़ता. You will be able to diagnose all the stones. All right. So ultrasound abdomen is the investigation of choice to identify the stone. Now suppose the patient also has a secondary UTI along with it, then you can do a urine analysis or you can do a culture of the organism and start treating him with antibiotics. Okay. If on ultrasound abdomen you are not able to find a stone, but patient presents classically with symptoms of stone, then in that case you can do a CT-KUB, okay, CT scan, to find out the smaller stones. All right. Again, as I told you before, you can do a DTPS scan. When will you do a DTPS scan? When you feel that there has been a distension of the pelvic ileal system for a long time secondary to the stone and the renal functioning could have been compromised. Okay. Okay, then you can do a urine analysis of the crystals to find out what is the component of the stone. All right. Okay, then what is the treatment of a stone? Now this is the more interesting part. So can anyone give me any one or two examples of what are the surgical therapies that are available for stones? Yes, so I'll give you some of the examples that we do. The first one that we do is called as a PCNL. That is the first procedure that you need to know about. Okay, what is the full form of a PCNL? PCNL is nothing but a percutaneous nephrolithotomy. Okay, now what do you do in this case? If this is your kidney, okay, you will pass under C-arm guidance. C-arm guidance, that is nothing but X-ray or ultrasound guidance. Nowadays, mostly they do C-arm only. You pass a small needle percutaneously from the skin into the renal pelvis. Okay. Once you reach the renal pelvis, slowly you will pass guide wires inside. So by passing guide wires, you will be able to, on top of the guide wires, you will be able to pass dilators. Okay. So you pass small size dilator, big size dilator, larger size dilator. Finally, you create a track over here. One track is created over here. Okay. Now what you do through this track, you will pass the nephroscope. Okay. So the nephroscope will be passed from here And the end of the nephroscope, what will it do? Imagine your big stone is over here. So the end of the nephroscope will fragment the stone. Okay. And once the stone has been fragmented, this path is already created. So from this path, the fragments of the stone will move out. Okay. Got it? I'll tell you guys again. First, percutaneously pass a needle. You will enter into the renal pelvis. How will you know you have reached the renal pelvis? You'll be able to see urine coming out. Okay. Through the needle. Then you pass a guide wire. Then on top of the guide wire, you pass dilators, small size, big size, big size. Once you have created a big enough tract, pass the nephroscope through that tract, break down the stone, remove the fragments of the stone through the entire tract. Okay, so that is how you do a PCNL. Now, what in the exam, what will they ask you? What are the important complications of PCNL? When you're passing the needle dilators, you can hit a lot of blood vessels. So the most important complication is there can be hemorrhage. Okay, then if you are going not in the correct direction, if you are not going towards the kidney, if you're going up or down, you can also perforate the pleura or the colon, whatever is coming in the way. Okay, if you go too up, you can perforate the pleura. If you go too down, you can perforate the colon. Okay, so this is how we carry out PCNL. The next one that you need to know. Okay, so this is an example of a staghorn calculus, guys. I put a picture of a staghorn calculus. Okay, the next thing that you need to know is about ESWL. Can anyone tell me the full form of ESWL? Okay, so ESWL is nothing but extracorporeal shock wave lithotripsy. Tripsy means you are breaking down the stone or you're fragmenting the stone. Okay, so what do you do in case of ESWL? So in ESWL, you use two kinds of waves. Either you use electromagnetic shock waves or you use piezoelectric waves. Okay, so you pass these waves through a good conducting solution. So what is a good conducting solution? Water. And then these waves will be incident on the kidney. Okay, so when these waves are incident on the kidney, on the ureter, these shock waves, they will go and they will fragment the stone. Okay, once the shock waves fragment the stone, the fragments will go out through the ureter. So that is how you do a extracorporeal shockwave lithotripsy. Currently, this is one of the most commonly used procedures for smaller stones. Okay, so if the stone is less than 2.5 centimeter, if the stone is already broken or you feel that it will get fragmented easily, you will prefer to do an ESWL in it. Why? You don't require anesthesia for this and it does not have many complications. Okay, and it can even be done as an OPD procedure. So you can use ESWL for it. But if ESWL is not possible, you will go ahead with PCNL, which we discussed earlier. Okay, so PCNL, you will prefer it for bigger stones, more than 2.5 centimeter, and the stones that are not responding to ESWL. So in ESWL, what are you doing? Nothing. You're just passing shock waves. You're breaking down the stone, and then the fragments of the stone will anyways be flushed out through the uretero and through the ureter and bladder. Okay. So that is what we do in ESWL. Alright, so PCNL and ESWL, two main ways of getting rid of the stone. Any other ways that anyone knows of? Can you do any kind of surgery? Can you do any kind of surgery to get rid of it? Sorry guys, one thing I forgot to discuss with you all, in whom is ESWL contraindicated? Okay, so if any patient has abdominal aneurysm, so because of the excessive shock wave, you can have a rupture of the aneurysm. So you will avoid doing ESWL in this patient. Second, if you have a pregnant patient, again in pregnant patient, ESWL is contraindicated. Okay, all right. Anything else that you can do? You can do surgeries. You can do a pylolithotomy. So what do you do in a pylolithotomy? In a pylolithotomy, nothing. What you do is you will open up the entire renal pelvis and you will remove the stone out of it. Okay. If the stone causes decrease in the function, renal function, you may have to remove the kidney So one part of the kidney where the stone has caused reduced functioning, so you can do a partial nephrectomy, or you may also have to do a complete nephrectomy on that side. If the kidney has gotten, if it has shrunk and lost its function due to a long-term stone, then the only option you have is to remove it. Okay, so these are all the options that you have for removing the kidney. One more option we have, I forgot to tell you about it. If it is a lower ureteric stone, you can even do a ureteroscopic removal. Okay, so if this is the bladder and the stone is somewhere over here, close to the lower end, okay, so you can even pass a ureteroscope or a cystoscope and you can retrieve the stone from here. But these are for smaller stones only, not bigger stones. For all bigger stones, you will prefer to do a PCNN. All right, so this is all about stones. So with that, we can finish today's class. Now I know a lot or more in uro is remaining. So today we were focusing mainly on the kidney. From tomorrow, we will start doing our urinary, bladder and ureter. Okay. So tomorrow we'll finish the remaining part that remains of uro. So I hope that this class was useful to you guys. And today's session was a little distracting, guys, because of all your comments. So please make sure only if you are interested in studying and coming for academic purposes, you are coming for class. Okay, because we are very close to the exam right now, so it's better that we focus on the important topics. All right, thank you so much, guys, and I shall see you next time, that is tomorrow morning at 11 o'clock.